Okay. Okay, so welcome. Thank you so much for coming. This is our quarterly Jerry Palliative Care combined grand rounds, and I am really pleased to see a lot of familiar names showing up in the participant list. And there are several people that I've invited specifically to join us because I'm actually hoping that this will be a really good conversation and discussion near the end of the presentation. So I'm gonna get started. Oh, and I should introduce myself. So I'm Annie Hirano. I am one of the palliative medicine and geriatric medicine attendings. So I feel like I have a relatively unique position in that I get to rotate on both services, and so have a little bit of a bird's eye view, and have the privilege of being able to practice both palliative care consultation and geriatric medicine consultation. And there are several services that both those services interact with pretty frequently. And some of those folks I've invited to join us today and be a part of this discussion. So again, I encourage active participation. So feel free to put things in the chat if that's where you like to comment or ask questions, raise your virtual hand. And feel free to unmute yourselves if there are things that you want to ask or comment on. Okay. So I have no disclosures. And I have a little bit of an agenda. So the first part of this presentation, I'm going to be talking about palliative care and particularly palliative care in geriatrics, and touching on what is primary palliative care versus secondary palliative care. How do the two specialties overlap in scope? How are they separate? And some differences, some similarities. And then for part two, I'm actually hoping to get a little bit more specific so that we can throw out some ideas and have a little bit of a discussion around what geriatrics and palliative care consultation and scope and practice look like in real life at Harborview in particular, which is where the majority of my clinical time is concentrated. Okay. So I'd like to get all of our brains warmed up a little. And I'm taking us back to basics. And I know this is way back to basics, but I'd like everyone to just ask in their heads, what is palliative care? And so if you could take a moment to just answer that question, palliative care is, and just formulate anywhere from 1 to 3 sentences. Think of it as your elevator pitch of what is palliative care. Somebody asks you and you're telling them palliative care is, and I'd like you to actually try to come up with a couple of sentences in your head, or you can write it down. I'm not necessarily going to ask you to share it with everyone, but if you feel like you are so inclined, you can definitely put it in the chat. But it's a little bit of an exercise to just see what comes up when you ask yourself, what is palliative care? Okay, and I gave us all about probably around 10 seconds of silence, which is around the amount of silence that physicians and other clinicians are encouraged to give patients and families when they are in family meetings or doing goals of care conversations. Does anybody know what the average time we feel comfortable with silences before we jump in and feel the need to say something when we're in these family meetings? It's about 3 seconds. So again, in palliative care, one of the tools we use is silence. So we encourage folks to give patients and families room to formulate their thoughts and talk about what's on their mind. And it's oftentimes in that last moment where you're on the verge of feeling so uncomfortable that you need to jump in, that patients and families can say something profound that changes the course of the conversation, and changes their goals of care or the direction of treatments, because you've given them time and space and room to voice their values and what's on their mind. Okay, so hopefully I gave you enough time and space to think about what palliative care is. And so why did I do this? Because I think palliative care still is defined in a number of different ways, by a number of different people. And maybe even all of us have very different answers to that question. What is palliative care? I think palliative care as a specialty has evolved over the last 10 to 15 years and evolved in pretty significant ways. And we'll get a little bit more into that. But I asked that question, what is palliative care? And I asked it of several institutions. And so I started out very locally with UW Medicine, which a lot of us are part of, in academic medicine in the Seattle area. So UW Medicine. And I was kind of surprised to go to our website, which I guess I haven't visited in a really long time. And hopefully Tony Bach is not amongst the participants on this presentation, because he would be disheartened to see that we still have the clasped hands of a lot of, you'll see clasped hands on palliative care advertisements or flyers, and as a pictorial kind of representation of what palliative care is and does. And Tony is one of the creators of Vital Talk, which is a communication tool, educational tool that we use in palliative care. And one of his more current projects is really kind of the branding and ways that we advertise and represent palliative care. And he has told me many times that the clasped hands are not what we should be using. So I encourage you to go to his websites and look up, what he recommends as alternatives. And oftentimes what he recommends as alternatives are people living their lives, right? Because that's one of the things that we think we do, is to really consider the patient as a person, out in their real lives, in the real world, not in the hospital, not in the hospital bed in front of us, not their disease, but the whole person. And that's part of what we feel we do in palliative care, is bring that whole person. Who are you in the context of your personhood, your life, and bring that into your care, and bring that actually to the forefront of your care. So our website, here at UW says palliative care, personalized care plans to enhance quality of life and provide support and empathy. So right there, that doesn't feel grammatically great. So it has, there's some work to be done there. So we should probably talk to whoever we need to talk to update our website. Okay, so looking a little bit broader. So now we go to the state level. So this is actually what is palliative care at the Washington State Healthcare Authority level. So you can see they say palliative care is specialized care delivered by a multidisciplinary team for people living with serious illnesses, focusing on pain and symptom management while also working to reduce stress and improve quality of life for the person living with a serious illness and their family caregivers. So you talk a little bit about the team approach and what some of the palliative care services may include. I'm not going to read those out, but you can see that it's interesting. Their palliative care team, they include physicians, social workers, spiritual care providers, absolutely, but they also include therapists, mental health providers, and definitely advanced practice providers. We have on our teams at UW and Northwest Hospital. But less so, I've seen mental health care providers and therapists specifically be part of our inpatient palliative care teams. Sometimes we have pharmacists. Okay. And then looking again, zooming out a little bit more, what is palliative care? And this is from the CMS Centers for Medicare and Medicaid website. So palliative care, so now looking at national level, palliative care is specialized medical care. So you're seeing some of the same language for people living with a serious illness, again, serious illness, and they say such as cancer, heart failure, and patients in palliative care may receive medical care for their symptoms. So also highlighting our ability to treat symptoms. And they say, or palliative care, along with treatment intended to cure their serious illness. Palliative care is meant to enhance a person's current care by focusing on quality of life. So again, quality of life comes up for them and their family. So not just the patient, but for the people around them as well. Okay. And then zooming out even further, this is from the World Health Organization. So you can see their definition down here is palliative care is a crucial part of integrated, people-centered health services, relieving serious health-related suffering, be it physical, psychological, social, or spiritual, is a global ethical responsibility. I'm not going to read the whole thing, but you can see the word suffering comes up in their definition of palliative care. Okay. Again, so why do I bring this up? So as I mentioned before, I think, you know, even within those different organizations, even within our own organization, I think people's perception of what palliative care is and does can be very variable. And not just people's perception, not just patients and families' perception, but also the perception of our colleagues from various specialty backgrounds, from various professional backgrounds, but those we interact with within our medical system might have varying ideas of what palliative care is and does. Okay, and then where, you know, what has popular media portrayed about palliative care? What does social media bring up about palliative care? You know, what has politics kind of talked about palliative care? I don't know if any of you are old enough to kind of remember several presidential election cycles ago where palliative care was actually really demonized politically in the political sphere, and we were considered death panels. And the concern was that we were people who were you know, going to kill grandma. So we don't do that. But and then there's this historical influence of you know, hopefully the whole death panel thing. Most of our younger folks don't remember that. But if you were around, like I said, several election cycles ago, that was a thing, and that might be something that some of our patients or their family members might recall in the back of their memory when they hear the word palliative care, and there can be negative associations with it. Okay, so what is it that I really do? So I've seen this meme around several times, and I just think it's illustrative of some of these things of, you know, who influences what we think of palliative care. And then what is it that we really do? What is it that I really do? Okay. Oh, so I had one more, what is palliative care? And this is at the CAPC level. So this is a national organization run by Diane Meyer and her team. And it's the Center to Advance Palliative Care. And she's done a lot of research on what people know about palliative care, what people think about palliative care, what they don't know about palliative care. And she's done a lot of interest groups on what resonates with the general public, the average person from various political, religious, social backgrounds. what resonates with them, what language can we use to describe palliative care in a way that is accurate, accessible, and doesn't scare people away from this specialty. So here's the language that they've come up with when they talk about what is palliative care. And you can see there's, again, several words that have resonated with their interest groups and their focus groups, and they're included here in how they describe palliative care. So we've seen this specialized medical care for people living with serious illness come up several times on several websites, and those websites most likely took it from CAPC, which encourages people to use this type of language. Okay, so the type of care is focused on providing relief from symptoms and stress of the illness. That's come up before as well, and you can see it's to improve quality of life for both the patient and family, and that's language that we've seen before in some of those definitions as well. And her team highlights that palliative care is provided by a specially trained team of doctors, nurses, and other specialists who work together with the patient's other doctors to provide an extra layer of support. And that's language that also resonated with folks. And palliative care is based on the needs of the patient, not on the patient's prognosis. It is appropriate at any age and at any stage in a serious illness, and it can be provided along with curative treatment. So all of those words were chosen very carefully in order to represent palliative care accurately and positively and appropriately. Okay. Oh, and Kate says CAPC is celebrating its 25th anniversary. So can see some chats when they come up. Great. Okay. So I know a lot of us are palliative medicine providers on this call, and I also know that some of us aren't necessarily palliative care providers. And so again, I know it's one of those basic questions, and I think a lot of us think we know what palliative care is and think we have an idea, right? You were able to come up with 2 to 3 sentences for your elevator pitch on what is palliative care. And I hope you got a chance to kind of compare what you came up with to what Diane Meyer and CAPC and other folks have come up with. And I think it's always an interesting exercise to see, was your elevator pitch and your 2 to 3 sentences similar? Did it contain similar language, or was it wildly different? And it's okay if it was wildly different. We all, like I said, we all have different ideas of what some of these things are. And so how important is it to kind of all get on the same page? So I included actually my idea of what I think I do in palliative care, and some of the language that I use in this is language that I do use when I'm talking to patients and families about palliative care and introducing palliative care to patients and families. Okay. So this is not what I read off to patients and families, but it's just a list of things that I think distill down what I do on palliative care when I'm consulting. So I'm a member of an interprofessional and often trans-professional team, and I think that's one of the things that makes palliative care so special. And I do use this language when I'm introducing palliative care. So if some of you have been with me for for palliative care family meetings, or when I'm introducing palliative care to a new patient or family that we have been consulted for, I do introduce palliative care as an extra layer of support and communication for patients and their families with serious illness, or who are I often will say who are in the intensive care unit, because oftentimes I'm seeing people in the intensive care unit. I don't say that I'm specifically an extra layer of support and communication for colleagues. However, I think that's one of the things that we do as palliative care clinicians is give our colleagues a little space to voice their concerns. We do provide that extra layer of communication, oftentimes between teams and staff, or teams and other teams. And so I think that that helps mitigate some of the moral distress that can come with caring for patients and their families who have been in the hospital sometimes for protracted periods of time, unexpectedly with severe illness, with, teams that have changed over a lot and might be starting to feel the fatigue of long and varied hospitalization and all the things that come with that. Okay. And I do think that one of the most important things that we do in palliative care is elucidate values and goals. So we go in, we get to know our patients and families, and we are trying to get at what's important to them, what matters to them, who are they, and what are their values. And I think even this language has changed a little, because if you had asked me even 3 years ago, I probably would have said, I want to go in there and figure out their goals of care. And the gold standard for palliative care is achieving goal concordant care. And now if you ask me today, I actually build the word values into what I think I do a bit more, because I think that we don't always, patients and their families don't always know their exact or specific goals. And sometimes they don't even know or can't even put words to their general goals or speak to their general goals of care, but they can speak to what their values are. And they can, you can oftentimes, just by talking to them and hearing about their life or hearing about the things that seem to matter in their life, what their values are and what's important to them. So I oftentimes now think of what we do as trying to achieve value-aligned treatment and care. And if we get to goal concordant care, that's great too. But like I said, for patients and families who aren't always able to speak to their specific goals, I often think of what we're trying to do as figure out what their values are and then align their treatment and care to those values. Okay. And then sometimes, we get consulted because the hospital course and a patient's hospitalization has been challenging for the patient and family. We rotate a lot on academic medicine. There's a lot of different teams. There's a lot of different staff and learners and attendings rotating from week to week. So sometimes we step in when some trust and rapport has been eroded by so many of those changes. And I see us as rebuilding some of that and giving time and space to that. And then, of course, we're trained in symptom management, complex symptom management, particularly in the setting of serious or terminal illness. Okay. So let me move on to palliative care in the context of geriatric medicine, because I think it's important to think about this. And I was somewhat forced to think about it very deeply when Gina, Dr. Kang, and I took on this review paper for Dr. David Wu, who was one of the Geri Fellows here and is now on the East Coast at Johns Hopkins doing geriatric medicine and palliative medicine as well. And so for those of us who have a background in both palliative medicine and geriatric medicine, it was an interesting review to take on to think about primary palliative care education for geriatricians. And you can see the date on this paper. We wrote this last year, so it's post-pandemic, and it was a review where we looked back at the literature over 5 years, so between 2018 and 2022, to evaluate what the educational resources were for primary palliative care education for geriatricians. Okay. And I kind of thought I knew what we would find, but I was actually very, very surprised. So I'm going to back up just a little and try to get a definition for primary palliative care. And this definition is on the older side, so it's now over a decade old, from 2013, from Dr. Timothy Quill and Dr. Abernethy, who are prominent figures in the palliative care world. And their definition of primary palliative care is that it can be provided by any clinician and represents a set of skills, including basic pain and symptom management and basic serious illness communication. So this includes discussions about prognosis, goals of treatment, suffering, and code status. And this is distinguished from specialist palliative care. So specialist palliative care is palliative care that is provided by an interprofessional team with specialty level training in palliative care. Okay, so the idea is primary palliative care can be practiced by any and all of us in medicine, and is sort of specialty level palliative care. And they give some examples, like I said, of what this skill set includes. Okay. So when we looked at primary palliative care education in geriatrics over the past 5 years, what did we find? And some of the questions that we asked were, how are geriatricians learning primary palliative care? And again, to do this, we did a literature review and looked at PubMed, which is the medical search engine. And then we looked at some gray literature in Google Scholar / Google, which is the commercial search engine. And we identified relevant articles, and again, the gray literature pertaining to primary palliative care education for geriatricians. And we used specific search terms like primary palliative care, palliative care education, serious illness communication. So from 2018 to 2022, how many articles do you think we were able to identify that talked about primary palliative care education for geriatricians? So come up with like a number in your head that you think we might have come up with. Yeah, great job, Kay. 3 is actually pretty accurate. So we actually found no articles that specifically referenced primary palliative care for geriatricians. And in fact, no articles mentioning, oh, it's your birthday and you're extra lucky. Okay, go out there and buy a Powerball ticket for, understand the jackpot is $1.2 billion. Okay, so we found 0 articles that actually use that term, primary palliative care. And that was actually quite surprising for me because even 5 years ago, I think, primary palliative care was a pretty common term that was in vogue and something that we tossed around quite frequently when we would talk about the level of education and training and skill set that we expected in our colleagues when they were engaging in palliative care practices with their patients. So our thinking 5 to 10, 15 years ago was that there won't be enough palliative medicine clinicians to go around. There won't be enough palliative medicine clinicians to match the need in America, to match the need globally. So how do we disseminate palliative care education and palliative care skills and training to all of our colleagues, to the medical community, so that all of us have at least some level of palliative care communication tools and skills. So what we called that was primary palliative care. And I think we had this vision that we would train so many people and they would learn these skills so adeptly and be able to practice them so adeptly that we would actually make ourselves obsolete. And that was actually the goal, was to get everybody in medicine to have amazing communication tools and skills, to be able to communicate with their patients and families, to be able to support their patient and families, and practice at this level, no matter what specialty and background you are coming from. Um, so that has not come to fruition. And it actually may sound kind of familiar because I think, we also recognize and know that there is already a shortage of geriatricians to meet the needs of our aging population, both nationally, locally, and globally. So it's interesting that these two specialties are encountering um, or anticipate such significant shortages. And I think both specialties are kind of looking to see like how can we train everyone up in order to care for the patients that we see on a pretty regular basis and feel we should all have skills in being able to care for at some level. Okay. So what was interesting to me was that there were numerous articles evaluating primary palliative care for other medical specialties, particularly internal medicine, surgery, nephrology, oncology, emergency medicine, cardiology, psychiatry. So if you do the same search and use the same search terms, including primary palliative care, and instead of looking for primary palliative care education for geriatricians, but put in any of these other specialties, you'll come up with actually a whole bunch of articles that mention primary palliative care education in all of these other specialties. So what's going on and why is that? Why is it that for the past 5 years, the geriatric education literature does not mention primary palliative care and hardly actually even mentions palliative care, but for all these other specialties, the uptake of primary palliative care is much greater. Okay. So one of the things that Gina and I came up with is that, geriatrics and geriatric medicine was trying to itself define and educate people on what we do in geriatrics. And some of the campaigns, and I would say sort of like branding and advertising, or rebranding even, that some of the great minds of geriatric medicine were thinking up were things like patient priorities aligned care, and the four M's or five M's, depending if you're looking at it from the US side or the Canadian side. And one of the five M's is what matters most. Okay, so this is patient priorities care, and this is from the patient priorities care website. And you can see they use a lot of very similar language and messaging. So choosing what matters, doing what works. I really like that. And their definition is patient priorities care aligns care among all clinicians with what matters most to their patients. It recognizes that patients are the experts in what they want to achieve from their healthcare, while clinicians are the experts in how to get them there. So doesn't that sound a lot like aligning or goal concordant care or values aligned treatment and care, and really thinking through how do we get at who our patients are as people and what their lives are like and how we can make sure that we're getting the treatment that aligns best with their values and their goals to them. Okay. And Kay mentions that patient priorities care is framed as concurrent care and is an iterative process for people with 5 to 10 years of life. So interestingly, also for people with with some form of limitation on their prognosis too. So we can definitely talk more about patient priorities care. And then I pulled this from Mary Tinetti and the University of Ottawa website when they were first disseminating the geriatric 5 M's. And so the 5 M's you can see here are mind, mobility, medications, multi-complexity, and this is the M that is sometimes left out in the 4 M's. And then what matters most. So under matters most, the focus areas are coordinating advanced care planning, helping manage goals of care, and making sure that a person's individual, personally meaningful health outcomes, goals, and care preferences are reflected in treatment plans. So again, that all kind of sounds like palliative care, like primary palliative care, but you can see on these websites that neither one specifically mentions palliative care, right? Or primary palliative care. That is not language or words that are used in either website. Okay. So being a part of these two specialties, it's been really fascinating to see how both of these specialties have evolved over the last decade or so. And and they're both continuing to evolve is something that I think I'd argue. So palliative care, if we look at, palliative care back in the day, it grew up out of the hospice movement, right? So hospice and end-of-life care. And I'd say we're specifically trained in comfort-focused care and pain and symptom management at the end of life and in serious illness and in terminal illness. And I think over the years, what we've evolved to is really seeing ourselves as experts in, again, that goal concordant care and really figuring out, what's important to folks in their lives and how that fits into their treatment and their illness. But really, expanding from patient is not their illness, patient is not their disease, right? Patients are people, they're whole people with whole lives. And so then now I think we kind of see ourselves as sometimes we call ourselves the communication team or the communication doctors. So really what we're evolving towards is a lot of vital talk and communication skills and tools and education. And then if you consult us at Harborview, a lot of the times we are engaging in patient and family support. So communication and support. And again, it's built into our introduction. When I introduce palliative care, at least, I introduce our team as an extra layer of support and communication. Okay, so what was going on the geriatric medicine side? And so this is kind of my my retrospective being in geriatric medicine. I did my fellowship clinical year in 2008 to 2009. So giving you a little clue about my vintage. And so when I first started training, I feel like a lot of our focus was on aging, frailty, geriatric syndromes, and that's not necessarily something that's changed, but I think that we've kind of moved from aging and frailty to really focusing on, again, the person as a whole. What does their whole life look like? How are we putting this person in context of their environment, in context of their social and functional status and their lives in general. And that's, I think, what the 4 and 5 M's get at, right? So it touches on their medical situation. It touches on their functional status. It touches on their cognition and who they are. And then it touches on what matters most to them as people, as humans. Okay. So hopefully you're seeing that these two things I feel like are kind of, again, two specialties are both kind of evolving and are now kind of overlapping in certain ways. So how do they overlap? I'm just checking the chat. And May says, agree that not calling out primary palliative care is common in Jerry is labeled matters most or concurrent care, since so many of us are also primary care providers. Yeah. So interesting, right? Because from a palliative care clinician standpoint, and someone who was involved in that earlier directive or charge of let's educate everyone and bring everyone's education and skill set up to achieve good primary palliative care for all. We're so set on, and for a specialty that emphasizes the importance of word choice and language, because we see ourselves as the communication doctors, and we know that word choice and language matter. We, we are used to the label of primary palliative care, and geriatrics has gone in a different direction because they were doing all of these things. This is not something that they needed to be trained up on, right? It's not something that geriatricians need to be trained up on. They were already doing this work. They were already doing advanced care planning. They were already doing goals of care. And so it makes sense that their specialty also takes ownership of it in patient priorities care and what matters most. So they're, to a certain extent, labeling what they were already doing. And though as a palliative care physician, I might see it from a palliative care standpoint and label it primary palliative care. Again, geriatricians were already doing this. And it makes sense that we would label it in our language as geriatricians in the context of what we were already doing. Okay, so this is a Venn diagram that some of you have seen before if you have come to some of my Jerry Pal talks in the past, because it's a Venn diagram that I've been working on for a long time. And I should have actually tried to find an older version of it, because it too has evolved and changed over the years. And I've refined it, I've added a lot of different things. And this is based on, again, the evolution I've seen in geriatric medicine, the evolution I've seen in palliative care, and our different scopes, the different scopes of the specialty. So what does geriatric medicine do? What does palliative care do? And I think I invite comments, invite arguments and discussion, because I am not the ultimate authority, be all end all. I don't think this represents everything. I think it's something that, again, I've tried to snapshot and build over the years to describe what I see as the scope of geriatric medicine and palliative care, what's unique about each scope, and then what's shared. And so you can see on my geriatric medicine side, I have primary care, right? Because geriatricians are often primary care physicians as well, primary care clinicians who diagnose and treat chronic medical issues and geriatric syndromes. They're adept at functional assessment and evaluation, and referral and coordination of care involving other specialists. And we engage in post-acute and long-term care as well. And then on the palliative care side, we do all the primary palliative care things, and we're often engaging now that a lot of our colleagues do have really fantastic primary palliative care skills. We're often consulted and working on the secondary and tertiary palliative care skills, including challenging family dynamics, advanced symptom management, and something that we call late goals of care. So that's oftentimes when there have been a number of goals of care conversations that I've had, but maybe the patient situation has changed and there's some prognostic discordance. And there can be prognostic discordance for many different reasons. So teasing that out can be a secondary palliative care skill. Okay. And then options of last resort, I would say, is within our scope as well nowadays. So voluntarily stopping eating and drinking, palliative sedation, and physician-assisted death. So some of those more ethically thorny or gray area topics that oftentimes need somebody with specialist training. And then palliative medicine clinicians are expected to know how to do a spiritual care assessment and tend to that. And we are trained in hospice and end-of-life care as well. Okay, and so what are the shared intersection overlapping scope areas? And so I listed advanced care planning, including I should put DPOA/legal next of kin, but durable surrogate decision makers, including identifying surrogate decision makers, code status, goals of care. So those three things oftentimes kind of go hand in hand. And then both specialties are adept at providing psychosocial assessment and support, assessing decisional capacity, managing symptoms, focusing on quality of life, and supporting the patient and their loved ones or family or caregivers. And so you can hopefully identify some of these things seen in both palliative care descriptions that I presented earlier, and in patient priorities care, and in the 5 M's, what matters most. So hopefully all of that is kind of familiar to both specialties. Okay. So that was kind of my first part one, and teasing out a little bit about, where are we now in those two specialties? How do we kind of see ourselves? How have we evolved a bit over the past decade? What language do both specialties use to discuss some similar skill sets? And so I am going to give folks a chance to bring up some discussion points for the first part, or ask about anything that came up for them during the first part. And we can take oh wow, I didn't do so well on time. We can take at least a minute if there's any comments or questions about that, because I will be moving on to part two. And part two, again, is definitely going to be a discussion. So I will bring up some questions that might help kind of generate some topics of discussion, and hopefully people are in a place where they feel comfortable joining in on that, either in the chat, or feel free to unmute and turn on your video if you're in a spot to do that. I see that Carrie has put in the chat, my impression is that the medical aid in dying topic, physician-assisted death, is more in the shared intersection of interests and expertise in palliative care and geriatrics. I agree. But this is, of course, very dependent on training programs and faculty expertise. And Kate says she agrees with Carrie, and I absolutely agree with you as well, both Kate and Carrie, because Kate and I have definitely had shared patients. And Kate and I have discussed that there are a number of patients who bring up medical aid in dying. We're in Washington State, which is a medical aid in dying legal state. So it behooves all of us with patients with chronic serious illness, and just in general primary care physicians and clinicians, to be able to address that and have some level of expertise in that. And then Amy says, Carrie, interested in your comment at the VA, we can't do, but had assumed if I was not in the VA, this is something geriatrics would be actively involved in, correct? So again, the Venn diagram has not been a static Venn diagram. It's something that I update from time to time as, again, both of these specialties are evolving in the care that we focus on and provide. Okay, so just in the interest of time, friends, I will move on a little because I did want to talk about the intersection of geriatrics and palliative care and what that looks like at Harborview. That's where I live in practice. And it's interesting because I feel like it's a ripe environment and area to see the intersection of palliative care and geriatrics in real time, in real life, in action. So at Harborview, we have a geriatric medicine consult service, the MedG service, and we have a palliative care consult service. So both are consult services, both are specialty consult care services. And where do these services overlap? And this is not the only places they overlap, but this is an area that I see where they often overlap. So at Harborview, we have the Geri T bundle, and we have folks on the call who are involved and have created the Geri T bundle. So I'm very glad you're here. And we can talk a little bit more about what that is and what that looks like. And then we have currently, I just rotated on MedG for the past 2 days, where we're looking at patients who are 70 and older who come into the TICU, the trauma ICU at Harborview. Again, patients 70 and older, and the residents are doing a bit of an auto assessment. So they identify those patients, and then they're reaching out to whoever is listed as the primary contact for those patients in Epic, and they're asking if we should come and consult on the patient and what the needs might be. Okay. And then I was trying to, I thought there were more attendings who rotated on both services, but am I the only one, May and Kate? I might be the only one right now who's rotating on both medicine and palliative care.
Gina King, Gina can speak to, she does many outpatient palliative care rotations and then is an attending on MedG.
Yeah, I know. I've almost put Gina down, but then I realized that Gina doesn't rotate on our inpatient service. So she doesn't rotate on our inpatient palliative care consult service, but that's right that Gina does.
Only you, Annie.
So yeah, so I think I'm the lone attending right now who rotates on both inpatient consult services. And then the Geri Fellows actually rotate on both consult services. And in fact, Sunit, who was on with me yesterday on the MedG service, I ran into her on the palliative care consult service earlier. So our Geri Fellows rotate on both services. Okay. Okay. So continuing along that line, what are the differences in MedG and palliative care? And there are a number of them. What are the differences in the two consult services? And I highlight a couple, mainly actually team structure, because it's something to think about. So on MedG, we have a geriatric medicine attending, we have a geriatric medicine fellow oftentimes. We have 3 internal medicine senior residents who are R3s. We have sometimes one PM&R physiatry R1, and we have medical students with us. On the palliative care side, this is a very attending heavy or driven service. So the bulk of the work is done by the attending physicians who bill by time, so who are often at family meetings, leading family meetings, heavily involved in and very hands-on on consults. So there are 2 palliative care attendings on service most of the time. We have an interprofessional team, so we have a full-time social worker, and we have a half-time spiritual care clinician as well. And oftentimes we have a palliative care fellow. We are lucky enough that the Geri Fellows, like I mentioned, rotate with us as well. We often have a senior resident, an R2, and most of the time they're internal medicine. And then we have oftentimes a med student as well. And so what are we doing? What are both services doing? What are some overlapping services that we both provide? And again, you'll see it's a lot of this kind of primary palliative care work. So advanced care planning, including identifying surrogates, goals of care, goal concordant care, value aligned care, getting at goals and values, decisional capacity assessments, patient family support. So again, this is my perspective on the things that I feel that we overlap on and that we do and that both services provide. being someone who rotates on both services. Okay. Okay, so I did not leave us much time, and that is my fault. And I know that I've actually reached out to several of you already and asked you some of these questions, but I present them here as well. And we might not be able to have the fully fleshed out discussion that I was hoping we could have, but I think it might be worth, depending on how you feel, about making time to kind of talk more in depth about some of these things, because I would love to hear from all of you about, you know, what your thoughts are on some of these discussion points. These are things that came up over my 2 short days on MedG, and just things that I've been asking myself over the past couple of weeks, months. But I think it's important to match our patients and families with the right consult teams. And this is not something that I came up with yesterday. This is something that actually Wayne McCormick had talked to me about, gosh, even over 5 years ago, probably at this point. But he used to tell me there's no wrong door. So when it comes to TICU consults in particular, I think in the early days when we were starting to field a lot more TICU consults, Wayne's directive to me when I was on palliative care or when I would attend on MedG was, hey, you know, we're here to help our TICU colleagues. So if they call you while you're on MedG about a patient who, in your assessment, seems like they would actually benefit more from palliative care consult, you know, you should be the one to go and talk to palliative care and go back to TICU and say like, hey, I think, you know, this patient might be more appropriate for palliative care. And maybe geriatrics would see them, but we would really encourage more of a stronger palliative care presence. Okay, similarly, if TICU went to palliative care and I was attending on palliative care, Wayne would advise me that, you know, if you see someone on palliative care who's in their 80s or 90s who has a lot of geriatric symptoms or is delirious and would benefit from a geriatric medicine consult, you know, reach out to MedG and touch base with the team and let them know that like this patient, you know, we're not able to have a conversation with them quite yet. They're delirious and plus minus they have family, and we highly recommend that you reach out to MedG. Would you like us to do that for you? And so there was no wrong door for TICU. We should be the ones, Palliative and MedG, to help our colleagues and figure out who should help the team out with the care of this patient. Okay, and then, you know, again, the evolution of our services and what we do, and we now have the Geri T bundle, which was very successful and actually was shown to reduce length of stay. And my understanding is the clinical frailty scale was used to help determine which service to consult. So the algorithm was kind of posted in the team rooms. My understanding is that the surgery residents would also go to this algorithm of, depending on what the clinical frailty score was, would triage patients to MedG consult, palliative care consult, maybe both consults involved. Okay, and now, being on MedG this past week, albeit for only 2 days, one of the things that I was thinking about is, you know, I heard that we weren't using the clinical frailty scale algorithm so much, and so what do we use? And I think part of that is some clinical judgment. But one of the things I was wondering about is, you know, should we think about primary versus secondary palliative care? So, you know, if there's any hint of challenging family dynamics or needing to rebuild trust and rapport, or do late goals of care or advanced symptom management, which all kind of fall under more secondary palliative care, is that how we kind of then triage patients towards more palliative care consult versus geriatric medicine consult, or maybe they get both if they have geriatric medical issues as well. So how do we think about this? How do we triage patients? And then who does it, right? Like who determines that there's challenging family dynamics or needing to rebuild trust and rapport? Who identifies that need? And so one of the things I talked to Ali about actually just yesterday evening was, with this, what could this look like? Would it look like team huddles? Could we grab the Med-G attending or fellow, the palliative attending or fellow, and the trauma coordinators and just do a huddle maybe once a week or as needed to kind of see which consult service best fits with this patient and family and their needs. Okay. I ran over.
Really, that was terrific. So this is May. Yeah. So just to make everyone clear, CFS, clinical frail scale, although it's wonderful, it's evidence-based, it just wasn't being done consistently. And even in the eyes of the best beholders, people had different views of whether someone qualified along that. And the literature is really moving to just having an age cutoff. And if the patient's, a downhill skier who has nothing, full code, wants everything done, then you just write a brief note to say as much. But geriatric assessment is in fact standard of care at many of our academic trauma centers. And I think the idea of a huddle, now that we're moving away from co-management of ortho patients, I think moving our huddle system, if the trauma coordinators can pick a time, maybe twice a week, I think Wayne has always championed huddles, and we've been doing them, but we've been doing them with ortho, where the fellow goes in literally sometimes 3-4 times a week into the team room and says, hey, who's leaving, who's coming? And I think moving that towards the trauma service might be the way to go. But I look for Ali and Andrea to give us their opinion on that.
Yeah, and Annie, I'm sorry, I have to jump off soon, but I did want to ask, I only have the palliative care and the TICU side. And so I don't want to presume the workload of Jerry, but I wonder, what I'm hearing is two problems, is that one, the criteria has changed from what the surgery residents are used to using with the frailty score, and also that it's been difficult to make sure that these consults get called and to know who to call. And so I wonder if for at least a time limited trial, like I'm at Harborview for the next month, say, would it be too onerous for us to huddle with palliative care, Jerry, because I feel like I haven't gotten to work with the Jerry folks at all, and then either Andrea or Jennifer, and we could run the list of the new geriatric trauma patients every day after TICU rounds and figure out who of those new patients, which shouldn't be too many, do they need Jerry or palliative or both? And then we can prospectively look at, are there certain criteria that we are tending to go one way or the other, just to help us build more of a protocol to recommend to the ICU residents who they call. And then can we, once we sort of figure that out, can we make it a new automatic consult button in Epic just to make it easier? I don't know if that sounds too difficult to do every day.
No,
for
Ali,
say the
I
next
love
month.
it. I love it. And I think because the CFS was not only not getting done, it was inconsistent. And I think some type of huddle and developing metrics, which is what you're talking about, would be great. And I think this next month is a wonderful opportunity with you and Andrea's and Katie's support. And we also have a Jerry Fellow this entire month, Sunit, who's experienced at the process. Right. Yeah. So yeah. Let's talk offline about setting that up.
Yeah, I think that would be nice. And Andrea and Jennifer, correct me if I'm wrong, but I think that would help a lot of the communication between our three teams so that we all understand, what our role is, what the question is for us, and how we can be most helpful instead of having to play phone tag between, maybe some of the TICU residents who may not have the full picture and say, oh, we don't really have a question right now. And then our consults get delayed.
And this is kind of off topic, but I would like to highlight for the geriatric medicine point, the CFS still should be done. It's not going to be the metric for geri consults, but it has so much value, and it is an automatic trigger in Epic. And we should encourage that continue to get done by nursing as much as possible, because it has value beyond whether or not it elicits a specific type of consultation. So just to make that clear. Yeah.
Yeah,
And
that is part of the
remember
that is part of the geriatric trauma bundle, is for the nurse to do the frailty score. And that's something that Jennifer and I have really been focusing on still, is to ensure that the frailty scores are getting documented, because we're using it for other, metrics as well.
Yeah, and Carolyn Blaney, who's been a fantastic partner on Geri B, and an attendee on Geri Clinical Council, wants to point out that there is a Geri Burn bundle as well, much smaller population, but that's had some outstanding pathways for care. Yeah, Carolyn, thank you for all your support over the years.
Great. Well, I want to thank everybody for, especially those for like sticking it out with me till almost 9:10 past the hour. So thank you so much. I wish I had allowed a bit more time for this discussion, but I think it's a good jumping off point. And I think all of you know me, hopefully have my contact information. And I hope that this, this gave kind of some perspective on the scope of the different services, and sort of where each service has come from and where each service is evolving towards. And I think that context is so important for patients, families, and for our services that each have their own almost personalities and cultures. And so I hope that this just opens up the channels for ideas and communication moving forward. And I think that we're privileged and lucky enough to work at Harborview, where we get to have this high level of specialty services available for our patients and their families, both in geriatric medicine and palliative medicine. And that overlap for our patients is really fantastic care. And it's something that is so wonderful to be a part of. So thank you again for sticking out to the end.
One more thing. I think it is absolutely a huge mistake to go to 4 M's from 5 M's. I am an internal medicine person first and foremost, and I think our family medicine geriatric colleagues feel that way as well. You have to be board eligible in one of those medicine specialties, and I think dropping that 1 M, I don't understand the history of it, but I am a bit of advocate for 5 M's and for Geri helping with all 5. Like, how could we drop multi-complexity? Kate might know the history. We could tell her, she could tell us, but it's crazy. Thank you. Sorry.
It's supposed to be woven through the other ones. It wasn't really dropped, but it's again like primary geriatrics versus specialty geriatrics. They're using 5 M's for all of the educational initiatives for students, residents, and fellows. So don't worry, May, the 5 M's are there.
A good point, May. That was one of the things that hopefully came through in my presentation, as well as that labeling matters, right? Identifying things matters. And Andrea and Jennifer, I'm just going to send you all actually the rest of my slides with some of the other talking points and discussion points that you can look them over, and May as well. And you can see if there are things that look attractive to implement or not. But I think again, it bears more talking through, because I think this is a work in progress, and we're making fantastic progress, and it's great. Our patients are getting amazing care. And I think it is a work in progress. So let's keep workshopping. Okay. Thank you all.
Thanks, Annie.
Thanks, Annie.